recommendations for changes to the agenda. And we'll go ahead and the agenda is circulated. We have a copy of the minutes from the November 29th Legislative Finance and Quality Committee.
Everything's set up, so
We have time to review them. First, do I hear a motion to approve them?
I make a motion we approve.
I'll second it.
Thank you, Jeannie. It's going to be basically, let me tell you that Pat and I are here as official members of the committee, and I have Billy's proxy. So we have no problem with a quorum, but you and Pat are going to be the ones making motions. All in favor, say aye. Aye. Okay, we'll go good on that.
Aye.
Yeah, that'll probably help.
Yeah, and if you want to speak up a little bit. You're going to be doing most of the talking today? Okay.
So Billy Kennedy couldn't be here today, so I am your chair. And so we'll move right ahead with your presentation, Mr. Singh.
I didn't look down, or I would have rejected to be here.
Can you hear us well?
Okay, so
I heard someone say, "Can you hear me well?"
Okay, good. I moved the microphone a
The
little.
microphone's when they're close to you and you're hitting them, it's like a lot of noise on the side.
Sorry.
They're like, stuff on papers and everything, but that's what makes it hard to hear.
Okay. Well, whoever's talking, they're going to try to be quiet, so you'll be able to hear.
okay, so if I'm moving on to page 3. If we look there, in case any of you have forgotten since last time, we get this data from the state way late. So the most current data that we have, from the state is from November 2018. And then you will see December and January are projections for what we think that we're going to have. If you look at the red line, you will see that we are below where even we think that we need to be. So we do have some quality improvement activities included for TCLI, both formally and informally, that the TCLI folks are doing. So hopefully those will show some improvement soon. But we are anticipating that we may have to pay a certain percentage of money back to the state.
As that is a super measure.
It is the super measure, yes.
So how much money are we talking about?
It is based on the percentage that we did not achieve, and the overall is 50,000. Yeah. So you can see that we're just falling a little bit short. So it won't be the full 50,000, but we would prefer that it be 0. So we are actively working on some quality improvement activities to try to increase that.
We spend about $100,000 on quality assurance. So good.
Okay. So on page 4, individuals currently housed year to date as compared to the other NCOs. You can see that even though we're falling a little bit short, we are still number 3 in the state. The next page, housing retention rate. Everybody's looking good on that. 5 and 6. We'll see what we're doing and see what we're doing in comparison to the rest of the state. And for that, we are number 2. On page 7, individuals in or at risk adult care home entry, newly served by IPS SC providers. Again, the most current data that we have from the state is November 2018. We did put some things in place and been working actively with our providers to get those numbers up and make sure that we're reporting accurately those numbers. And it seems to have made a difference. And as you look towards December, January, you can see that our projections indicate that we should be in pretty good shape on this as we wind down toward the end of the fiscal year. Hopefully those trends will continue. Just a word of caution though, with the state does some look behinds behind the providers and behind us, and so these numbers may fluctuate. So if we send in, they request a certain percentage of what we're sending in to them, and they are going to look behind on those. So the 8 may go to a 7, or it could go to a 6, and potentially it could go to a 9, just depending on who they're asking for.
So what are you doing to the diversion to keep them, if they're at risk from going in?
So the TCLI folks work with them directly, and the state has developed a new system. You may recall we used to use PASSAR. We no longer use PASSAR. They're calling it RSVP. And so Carla actually heads that up, and she'll speak more about the specifics of it. But basically they have to come through us first, and we try to divert them from going into an adult care home. And it is supposed to be more streamlined than what the PASSAR was, because most of the time when we got the PASSARs, the folks were already in the adult care home by the time we reached out to them. So now their first contact is with Carla and her team. Carla, you any more specifics?
So we end up getting a lot more, like individuals can refer themselves, which I don't believe was being able to happen before. We have providers that are referring them, so we're getting a lot of them that are not already in adult care homes also. But I believe the number, we started this in November, and we've had 687 referrals since November.
The target of 4 is established by the state
I mean, it would be
based on population.
Well, there's not really a target for this, so it's just whoever calls in, but the target for us getting people into housing is established by the state, and it's a multi-tiered target where I think it's 50%, I'm looking at mine, 50% of all people going into housing is just spread evenly among the LMCOs, and then the rest is based on past performance and a percentage.
Wow. And you give us the 4 that's in
Yeah. So, any other questions?
And that's not a supermarket.
This is not a supermarket, no. So on page 8, you can see how we're doing in comparison to peers. Again, this is just data through November of 2018, so it does not reflect the good months that we had in December and January. So on this one, we're 75%. Page 9, individuals with documented in-reach contact. Everybody in the state is doing well on this. It's reflected on page 10 as well, so no concerns there. Page 11, housing status 90 days after housing slot issued. So we're still at 100%, and we are tied for the lead in the state with Sand Hills on that measure. Page 13, individuals who received housing slots within 30 days of agreeing to transition. We don't really have an internal way to determine where we're at with this. So the best that we have is the data that the state's providing to us from November 2018. And so we continue to be at or above the red line, which is the benchmark. And then you can see on page 14 that we are actually leading the state for this measure. Page 15, in-reach contacts that resulted in a decision of transition. Historically, we've always been less than 2% on this for the most part, and overall we continue to be at 2%. So we are last in the state in regard to this measure. It is not a super measure. And we would like this number to be a little bit higher, but in the places where it counts, we are performing what we should be.
So these are identified as at risk, which, and then in reach means
In reach is an individual is in the adult care home.
they're in the adult care.
They're in the adult care home already, and we're going in to talk to them to try to offer them the option of living in housing in the community. And this measure is really looking at the percentage of people who say yes after we have talked with them. And the numbers sort of fluctuate each month, but on the average months, we're talking with about 600 people. And so, 2% of 600 is not a small number, and it would exceed, if they all say yes and we get all of them in the housing, it would exceed our housing requirements.
Why do you think we're last in the state on this one?
Well, I don't have any empirical evidence. It is a measure that I think that you or someone could artificially adjust if they so chose to do it.
Self-reported, in other words.
Yes. But we report what we do as accurately as possible.
I mean, it makes it look like everybody's living in a nursing home in our part of the state, like where they're living. And I don't believe that.
Right. But there are a lot of factors that go into someone actually saying yes to move out into the community. There is the fear of the unknown. People may have been living in a nursing home for 12 years, 30 years, and having to go out in the community. Then there's also the influence of guardians who, if you know that they're in that nursing home, that you can call any time of the day or night, and the staff person can say, yep, they're here, this is what they're doing. If you're living in your own apartment, you can decide to go to Walmart, or you can decide to go down the street to the movies. If that guardian calls and you're not there, then there's that fear. So there's a lot of things that play into someone actually saying yes to living in the community.
Can I add something to that for you?
Sure.
In talking to the TCLI staff, one of the things that they also try to do in our counties is to make sure when that person says yes, that they're genuinely ready to make that move. And so not just kind of a flippant yes, but yes, and we kind of have a plan for how we're going to do that.
So they have to be appropriate.
That's right. That's right.
Anybody have any other questions from North? We'll head to corporate performance measures. Thank you, Mark.
You're welcome.
There's a lot of slides in the packet this time, and so I'm going to cover some of the important ones and then any questions that anybody has. On slide 3, this is the slide where we do just list the ones that have been met for long enough that we don't fully show slides on them. So these are all measures that we're still meeting or exceeding the standards on those. On our super measures slides here, the first one is our preventative care for innovations members. That, as you can see at the graph at the bottom, is one that we have been far exceeding for some time now. So we have very strong performance on this particular super measure. On the members housed through DCL initiative, Marvin's actually covered this in more detail, so I won't spend a lot of time on that. And he's also mentioned that we do have a quality improvement activity where we're working with this team, so you've seen this information.
Well,
Sure.
I sort of did a little math, and I ended up with a line, between those two. That frequently was at 0. So
That's one of the things. Yes, go ahead.
I didn't understand. Are we committed on housed or housed minus separated?
Well, this is a change from last year. Last year, the goal was 6.58 people moving into housing every month, and we met that and exceeded that goal. So this year, they have changed the measure. And so the way it works this year is if you move, we have the goal at the end of the year. But for each month, if you move 10 people into housing, but 5 people move out, we only get credit for 5.
Right.
And our main objections to this system is that some of the reasons that people are no longer housed are out of our control.
Sure.
If they move to a better place and get a job, no longer need our assistance, that still counts against us. If somebody dies through no fault of ours, that also counts against us. So it is a little bit different way of looking at housing now.
Are we in trouble? I mean, it's like there's a hole in the bucket.
One of the delays that we've also had is several housing developments in the area that are set to open but have been delayed over the course of months. And we have a fair number of individuals that are set to go into those slots. And as soon as the housing is available, they'll move in. But the physical building hasn't finished yet. On the follow-up after discharge, this is the DMH measure first. One of the changes that happened a while back is that follow-up visit's calculated at 1 to 7 days after discharge. We were also calculating 0 to 7 before, so it did change some things for us. If you see at the bottom on the mental health measure, we're just below the line. And for the SUD measure, we have been below on that one. And there are a number of things that we're working internally to try and bring those numbers up, including quality improvement activities.
One more time, if you may.
Sure.
DMH versus DHB.
So Department of Mental Health is the, I'm about to do it too, the state funded funding, and then the DHB is the Medicaid funding.
Okay.
Yeah, I should have written that out, sorry.
And I have to ask every time. And the substance abuse, so the problem being changed from 0 to 1 day is if you make contact with them the day they're discharged, it doesn't count.
Correct.
So you have to find people the day after they've gone, wherever they've gone.
That's right, which is a little more difficult.
In the business meeting, let me touch base and ask something. We providers, of course, just trying to work with Vaya on making sure they can meet this super measure. And as you can tell from their report, I think most of the NGOs are struggling with it. And there are a lot of barriers. One that you just pointed out, there are signs after they have been discharged, particularly when they're feeling better. But there's a lot of barriers to meeting this. So the past, just last month, we had a lot of discussion about this, and
2 here, it mentions that hospitals utilizing member services for follow-up appointments. That's actually one of the quality improvement activities that's being worked on to try and find a way to catch them before we sort of lose sight of them. So they're actively pursuing that right now. What we did add in this particular set of slides, the graphs that you'll see after these, is a comparison between the MCOs. One thing to remember is that there is a pretty big lag in how we get the data, so we're presenting it as we see it. So with the December data that this was presented with, July was the most recent we had at the time. So you'll see here us compared against the others at that time, just to get a snapshot. And then there's the DMH behind it on substance use, sorry. Our follow-up after discharge for the DHB, we've been a lot more consistently above the target there. Our mental health has been solidly above. And our SUD has some up and downs, but we're working on stabilizing that out pretty well. And again, the same QIAs that we're working on there to bring those up.
What's the difference? Why are we no success with substance abuse when they're negative?
It does have to do with the funding sources. So, a lot of times people that are on Medicaid may already have existing providers, some other resources that they're already tapping into. And again, there we have after that is the comparisons against the other MCOs. Both of those. And you're able to take over to your own compliance log. It's up.
So for access to care, we've put this back on the log because the last three submitted access to care reports fell below the standard for routine calls. And currently we have, the QIC, Quality Improvement Committee, has approved a business case to initiate a quality improvement activity around improving this measure.
Can you tell us about the timeline of that quality improvement activity? How long do they take to put into effect? Specifically, when is it going to begin? How long does it take to go through?
We've already done it was approved actually yesterday to move forward with it.
Yeah.
And we have an idea really of how we need to go in regards to interventions.
Okay.
One of the issues being prison discharges, so we're focusing on that because it's the state side that's really bringing the numbers down on this.
Yeah, we beat the Medicaid side.
Right.
So it's moving.
It's happening. Okay.
Yes.
Well, and it also will help. We're moving towards Ncqa, and so this is one thing that they really like us to look at. So that'll help us there as well. For the next slide, the CDW episode completion, we have met this 4 quarters in a row. This will be coming off the log, and we will be monitoring it. If it falls back down, we'll be bringing it back. But hopefully we continue to meet the standard on this one. CDW discharges, again, we've met this for 3 consecutive quarters, which is usually 3 reporting periods is when if we've met it for that, we'll take it off. But again, this will come off the log after today, and then we will monitor it, and if it falls below, we'll bring it back on. And good news, third one, the NC supports needs assessment. Again, we've met this 3 consecutive quarters, and we will be removing it again off the compliance log after today, and keep monitoring it as well. Timely submission of innovation incidents. We have been falling below the standard for the last 3 reporting periods. And currently, there is a quality improvement activity that is in place to bring these numbers up for timely submission of incidents in regards to innovation.
So we hope by the next time we meet, we will be above that level. And be able to continue that.
We've done efforts before, and they kind of felt, and they improved, and then I think those kind of, when we stopped doing those, they dropped below, and we're going to reinitiate a lot of that and push. So, but there is a process in place to improve that. The network
Is that
adequacy.
data adjusted? Is that data adjusted for all the times the incident reporting system is down? It's down quite a bit lately.
Actually, I think what I was listening yesterday when it was presented, it seemed like one of the issues has to do with weekend reporting. So that seems to be when, like, when something happens over the weekend. That's usually the delay in reporting. We're not quite sure, but I know they're working with providers to find out why and what can be done to help improve the process. But as far as I know, it does not include the times when Iris is down. I can't look into that though, if you like, Jeannie.
No, that's okay. It was just a thought I had. I can almost understand why we could find a problem if they don't have access to
Well, the other issue is, right, the other issue is that these are strictly for innovations. It doesn't include all incidents submitted into Iris. It's only for those, this measure is specific to innovations. So there aren't a lot of those. So when you don't have timely reporting, it can really pull those numbers down.
Got it.
Yeah. So for the network adequacy and accessibility analysis, the only primary update for this is the fact that it was completed and submitted on the 30th. So essentially, they requested, after review, or they requested additional information related to the special populations for TCLI, and that was submitted. As far as I know, this will probably come off the log and we'll close it. SB 99 solvency report. The state has developed, essentially the state developed a method to determine viability of LME NCOs by establishing short-term, intermediate-term solvency standards. They are looking or arranging a way to develop a corrective action plan by working with the LME NCOs. So as soon as I get more information on this, it's a little vague today, but as soon as I get more, I'll bring it.
Well, you know, my reaction to reading that was good luck.
Yeah.
Working with the state to tell them you're going to have money in the bank when they cut funding every year. It'll be interesting.
It will be interesting. But I'll let you know as soon as we find more information out of it. So it's a little vague right now.
And we continue to make payments for services that were previously cut, so we continue to do it, which has negatively impacted our fund balance.
Right.
And what most people in the public don't understand about the fund balance is that there is a certain amount that we are legislatively required to keep.
Cannot touch.
And we cannot touch. And so we are right there at that line now because we've chosen to continue to provide service dollars for little cuts.
So the next slides involve the external quality review. I'm proud to say this year we scored the highest we ever have. And we only had, we met with a score of 94% and 6% was partially met. So we didn't have any non-met scores. That's great news. It really was probably one of the best reviews we've had with CCME when they've come in. So I would really say this one was the most collaborative, helpful review we've had so far to date. Also, we have, how many works? We had 6 outstanding corrective action items that we're still basically waiting for a response on. So I have not heard an update on that. Have you?
So we've not received the response from CCME, but Tracy and I met with DHP. There were 6 areas, but it's really
It really is
6
more.
items, but it was really just 3 areas. So we've come to an agreement with DHP about what we will be doing for those. But as Andrew said, we have not received the official response from CCME yet.
External quality review is going to be ongoing, or is this what we're going to replace with NCQA?
No, this is separate from NCQA. NCQA is the accreditation requirement.
Right.
And then the external quality review is what the state contracts annually for them to come out. So, because accreditation really is every 3 years, so this occurs annually.
Right, okay, this is really DHB determining if we are following our DHB contract. DMH sends folks out as well, but it's the DMH contract's not included in this.
And then the first, if you see the first slide, it really shows how we've done progressively since it began, since the inception. And then each slide breaks it out by section for us on how we did in each area. So for the Ncqa update, we have had a shift in our timeline. We realized it was a little more aggressive, especially with some of our other initiatives around the 1115 waiver. So we're trying to align all of that so we're successful. We're looking at going live with Ncqa as of August 1st. We have to have a 6-month look-back period per their requirements. So our submission date for their tool will be the beginning of February. We'll be contracting with them this May. They have an interesting way of kind of doing things, I will say. So, and then we'll have an on-site roughly in mid-March, mid to late March, with an answer coming in April, which for us is our goal is to have that done before the tailored plans are awarded. Right now we are on target. I will say we've gotten a lot completed. We're moving in the right direction. Policies are being reviewed and coming through the system, and so we're in good shape right now. There are a couple of areas of concern, but we are addressing those. Part of that has to do a little bit with the communication between us and Ncqa. They are not as forthcoming with information, especially around clarifications on things, and so we're trying to get that information. Some of it's been conflicting, but we're working through it. Right now, there's really only 3 areas. We're still kind of trying to iron out, but for the most part, we've got a good handle on most of this.
They'll spell out the details in the report. They'll spell out the details in the report they give you after.
Oh, yes, they will.
That's how it works at the hospital.
Yeah, my understanding is they give you a chance after you submit your tool. They give you an opportunity to kind of come back with more information, and then, yes, they will let you know exactly what's missing, and that final report is posted. So we want to do as well as we possibly can. The goal is to, of course, not have any issues. That's always my objective.
This is back when they don't mind maybe manned by folks who are just new. So depending on who you get,
they have a lot of
little
interns.
Different answer, which is going a little bit confusing.
They also have an incentive not to give you 100%.
I know, and I really strive for that. I was a little upset with my 99.6% I got with your act. So.
Because they put them out of a job.
Well, they do. I will say they have a lot of interns up there. We went to a conference. They're very nice people. I can't complain about that. But they do have a lot of interns manning the quality, or not quality, but the question and answer portion. And so a lot of times we get one answer, or they redirect us back, and then we have to ask again, and that goes to another person. So we get an audit, and it never. So we've had to actually have a call with them, with a couple of their policy experts to kind of clarify some of this, and that's where we're at with it.
And of course, we're doing all of this trying to get ready for gentlemen as well. So,
We're ambitious.
I'm not going to ask the number of FTEs that are assigned.
You don't want to know. Yeah.
It's scary.
There's not many.
I'm really working her 80-hour weeks. So.
Yeah, long hours. But I believe, I have all faith that we can accomplish this. I've gone through a few reviews, so I'm pretty confident. But the next slide is around our internal audits that we've been doing. So the implementation review for the Registry of Unmet Needs was completed and approved, and that letter went out. I can also say a quick update because this just happened. The housing audit plan of correction was approved. The implementation review was conducted and we approved that, and that has been closed out. The claims audit was completed. There was no plan of correction for them. We also did a specialized audit of the Quality Improvement Committee, and the summary has been finalized and steps have been taken to bring the reporting requirements into compliance. And an audit of the Network Performance and Integrity Department was just completed, and we just sent out the summary for that to the team and the plan of correction, and we're waiting for them to complete that and send that back to us for approval. And we will be conducting, we're working with care coordination right now to do the fourth hour, the additional audit that we're required to do on our compliance plan. It looks like we'll probably be looking at the HRA, health risk assessment is what that is, and how they're completed, and making sure they follow the guidelines. So that'll be our final audit for this fiscal year. And just to give you a heads up, next year we'll be looking at Ncqa files for the Ncqa on-site. And so that'll be part of our compliance plan moving forward.
You get bonus pay for a pass.
You get bonus?
You get bonus pay for a pass.
I have no choice. Do I get bonus pay if you pass? And I will turn it back over to Kate.
Thank you very much.
You're welcome.
The next, of course, the rest of the presentation is the core performance measures, and in the interest of time, I won't review all of them. I'll let you ask questions. We will look at the first two, though, which is the percent receiving services, which are always really important. The Medicaid there, you'll see, you have to kind of ignore those last two red numbers there, since those are not mature data. The numbers were a little down. They're improving a little bit since then, so fairly steady and doing pretty well there.
What do we think is an appropriate target for penetration?
For penetration, I mean, we tend to stay around the 10%, but you know, the higher the better on that one.
Is that a happy number?
It means we're providing services to the community, and that's an important feature on the penetration rates.
Okay.
Yeah. And then the state one has been pretty flat there on that second slide. So that one's holding its ground. Again, there are a lot of slides behind this. Did anybody have any questions about any of them? Or can I talk about any of them?
I think the readmit rates are going up in a couple of areas, such as abuse and mental health, for Medicaid and also for the non-Medicaid.
That's right, and we have noticed that they are up, and so we are looking at those. Provider network and care coordination are looking at those numbers. We also took a different stance this recently and started comparing our trends against the other MCOs over time to see, and the patterns are very similar on these. So it is some sort of statewide patterns that we're looking at. But we are looking at what's actually happening to cause these to happen right now, to get more details.
It's complicated, I would think.
It
All
is.
the different factors that go into whether somebody gets stable after they leave the emergency room or the hospital.
That's right, and that's why we're, yes, both sets we're reviewing right now to try to figure that out. In the last few months, the numbers have started to come back down a little bit, but you just won't see that yet in the graphs. And any other questions about any of the data that I can review for you?
Anybody else? Judy?
I'm good. I'm good.
All right, monthly. MCO monthly comparison reports, which I find to be the least exciting thing, because I just think, just because we're doing better or worse than one of the other ones doesn't mean either one of us is good or bad, so. But we can look at all those. So can you just tell us about those MCO monthly comparison reports?
Yeah, and on those again, we slide down there in the slides. Again, the big ones that we really do look at is those percent of enrollees receiving services there. Against the other MCOs, if you're comparing us, we do still, on average, we do have the highest average against the other MCOs, which means, again, we're providing services, and that's both Medicaid and state that's the case. We've had some folks sort of catching up with us, just means more of the state is getting served, but we're definitely very solid on both the state, or the Medicaid and the state funded on those.
The other thing that, like on page 51, the numbers are such small as to be laughable, and I just wondered if, rather than giving us a monthly, is that a monthly number?
It is, that's a
If we could
December
just,
snapshot.
maybe like a rolling 12 months. or
That's actually
something.
where we're headed.
Oh, okay.
Just this past month, meeting with BLT, they made that decision, so you will start to see that.
Okay. I think just like the genius. Okay. Yeah, that's
Because you're right, I mean,
useless
4,
information.
right, to be 20% in 4 it is not all that notable.
Yeah, okay. Yes. However, Jimmy, do you have any questions on this?
I know.
Yeah, my main concern is that there's small numbers on many of these that just.
Right.
All right, let's move on.
All right, so this is for second quarter, October 1st, 2018 through December 31st, 2018, which is the last quarter we reported out on. Because in April we'll do third quarter. The non-emergent, or excuse me, the emergent, which is to be seen in 2.5 hours. The standard is 97%, and we met that at both Medicaid, non-Medicaid combined at 100%. So all of our emergent members were met in time. Urgent, which is 2 calendar days that they received their services face-to-face, and the state standard is 82%. Medicaid was 85%, non-Medicaid was 92%, and so our combined was 90%, which is really good. Our routine, for our routine appointments, which is 14 calendar days, the state average is 75%. Medicaid, we met that at 85%. Where it hurt us was our non-Medicaid state funds were 60%, so we missed it by 3% overall with a 72%. And Andrea said before, we did get yesterday, we've been doing some work to get a QIA in process, so we have approved to do a QIA specifically only on the non-Medicaid routine, because that's the only one that we've been missing. So it's not the whole routine, it's just the non-Medicaid. And just for this quarter, because I've been given updates on the prison discharges, because that seems to be the biggest impact of why we're not hitting that number. There was 48 prison discharges, and 16 of those made it to their appointment, which is actually higher, but still, that was 33% only made it to their appointments out of the prisons. We did have a discussion with the state, was that last month, Marvin? About the access to care report, and we talked about the prison discharges. It seems like the other MCOs that are in the same situation, that have prisons in their area and have a lot of discharges, are under the same situation as we are with the prison discharges. They're not getting them to their appointments afterwards either.
Prison discharges, obviously a high percentage of people in prison mental health or substance abuse.
Yes.
It's not 100%.
No.
How do we identify who is in that discharge population?
So if they had a diagnosis when they went into prison, then they're going to get an appointment when they're leaving the prison, or if they get diagnosed while they're in there. So, and they all lose their Medicaid if they did have Medicaid when they went in there. So that's why they're all state funded. But, yeah, so it's not all prison discharges. It would be only ones that have actually a diagnosis of substance use or mental health.
An idea what percentage it is?
I don't. I do not know that. Because I don't know the number of prison discharges overall in the state.
There's some things that we can fix and some things we can't.
Yeah, it's going to be a challenge, I think, because I know that we shared with you guys, we sent those letters out to all the prison, to the social workers, and hoping that they would work with us we really didn't see a result in that. So we're going to have to brainstorm some other ideas to hopefully have the prisons help us get these people to their appointments. There's a big barrier with being able to contact them afterwards because most of them don't have phone numbers that we can contact because they weren't supposed to have phone numbers in the prison.
Need legislation to tie their reimbursement cooperation. It's not going to happen.
I like that.
I mean, who cares? I mean, in some ways, who cares the prison?
Yeah, it's and I think what I'm seeing when I'm kind of looking at these logs and everything with we're seeing repeat offenders going back into prison, and I'm getting another prison discharge. So they're not going to their appointments, and that's recycling them back into prison also. So, kind of like that hospital maintenance.
Yeah. And there's no way to intervene on a person at risk when they get in trouble with the law again. That like we can't help them go through mental health first before they go to work.
Yeah, I know that one of the things that we're looking at is trying to build some relationships with probation officers. Because all of these will have probation officers coming out, and maybe trying to partner with them. That's one of the ideas I was coming up with to maybe help us maybe influence these guys to women to get to their appointments. Thank you.
Yeah. Any other questions?
Because they'll be there for their appointment.
Right.
And agreements.
Okay, so we're looking at a calendar year, 2018, specifically quarters 1 and 2. Today, little summary of what we're looking at for those 2 quarters. We saw a decrease in quarter 2. We generally do see a decrease that time of year. This time it decreased almost by half, so we went from 97 to 55. We referred 26% within these 2 quarters for formal investigation, and that's when we identified that the allegation warrants more than an informal review, that needed a more formal investigation. We did have some specific provider trends regarding opioid treatment. You'll see that in top services. Those were also referred for investigation. And we did see an increase in residential treatment allegations regarding residential treatment services. In quarter 1, 7 of those seem to be a licensing issue and were referred to the North Carolina Department of Health and Service Regulation as their oversight. So if you look on, you'll see the pretty big dip right there. And if you look when types of grievances, they're almost essentially cut in half on some of those. Allegations of abuse, neglect, exploitations are way down. And quality of service is generally sort of seems to be a catch-all category for most of our complaints and grievances, so those stay pretty high. So this is what I talked about before. You'll see the top 5 for opioid treatment. That's when we started to identify some trends over the past 2 quarters. Other sometimes includes a non-identified service, but it also can identify a service that's not within Vaya's purview. And with those, we try to refer them to where they need to go to voice their concerns. And you'll see the big decrease with residential that I spoke about before. And there's a big decrease in the outpatient. These are the grievances complaints against Vaya. So those continue to decrease. The next is level of review, just to kind of give you show you. So we did increase the ones that went to formal investigation this time, and that was identified trends, allegations of potential non-compliance with service definitions, contract, things like that. The next wrap is, this is our days to resolution. 30 days, that's our goal. We consistently met that, and our average is just a little bit more than 10 the past 2 quarters.
Didn't you present us one time with sort of a bar graph that showed we had some that were like 90 days that took forever to resolve, and they were making our average? No? I thought we saw one that showed, where we sort of had a timeline of when they initiated, when they were resolved, and some of them were like,
I think it's been a while since we've had one that went over, I think it's been almost a year since we've had one that went over 30 days, but.
Well, I can't remember last week.
We've been in compliance for a while.
Okay.
But yeah, we did have the period where we had a couple that had to go outside of, and sometimes they need to go outside of 30 days for whatever's happening in that situation.
Also, didn't we see a big bump when there was the legislation in the state that sort of, words are failing me, but sort of cut back on the definitions for who qualified for services? And somebody help me out.
Would that
When they
be?
did
Would that be in regards to the resource allocation letters,
resource
the budget letters?
allocation letters? When did those go out?
We need to know, August 2016.
Okay, so that would.
Trying to catch up.
And we
We
did
did
have,
have a big bump then.
we did have a big
Are
bump
we still
then.
coming down from that, or is?
We're still seeing this.
We're still seeing
We
some.
expected a bigger decrease over time as, people sort of got used to getting these letters.
Yeah.
Not as big of a decrease as we had thought. We're still continuing to get those.
And that's something that's outside of our.
Yes.
No.
And you'll see some of that trend reflected in the appeals when you get.
That's very good.
And then the next 2 tables are county-specific data. The first table is the county where the provider is actually located. No huge surprises there.
Oh, really?
We know you
I
have
found
more
some.
providers in Buncombe County. And then the next table is by county of eligibility. And that goes per rate of 1,000. And if you look at some, like for example, the one on top, Alexander County, when we're looking at only 2 grievances, but we look at 615 unique individuals served, that rate kind of goes up. And there was no huge surprises there either. Do they have any questions?
Yes, I do.
Okay, this is the denial and appeal for Medicaid services for quarters 1 and 2 of fiscal year 2019. So that is July through December of 2018. And this is one, Dr. Kahn, which we do aggregate data and then look at it trended rather than looking at it monthly. When we look at it monthly, there's just so much noise or variability that it makes it very hard to see trends, but quarterly has proven to be very helpful in that regard. This is different than some of the reports that you're hearing today in that there are no established performance standards, but rather we look at the data trended over a 3-year period and then look at changes or variations and try to interpret that and see what that means and what action is needed. And just a heads up, for these 2 quarters, we're not seeing any significant changes in denials and appeals that were unexpected. So we start by looking at the volume of requests for services. This is what we call the Sar volume. These are processed Medicaid SARs. And you'll notice that back in quarter 1 of 2018, there was a drop. But that was when a number of services that had previously required prior authorization no longer did. So the number of requests we got. And then when you look at quarter 4 of 2018, there was an increase there, but that was attributed to an increase in some of the Medicaid B3 services that we offered. So there were more services that were requested and the Sar volume went up. We then move into looking at the clinical denial rate. Historically, for the last few years, we have averaged around 2.5% of requests for Medicaid services result in a clinical or medical necessity denial. But then there are changes in that, and this is where looking at the trended data is really helpful. For example, if you look at quarter 2 of 2018, where the denial rate jumped to 3.6, coincided with the rollout of the resource allocation model, and there were more service requests that we were not able to approve given the new parameters that we were working with.
You just said it was 16.
Then we go on to looking at the number or volume, percentage of denials that are appealed, the first level appeals that we do here. They're called reconsiderations. So again, if you look at the trend there in both, there are two graphs there. One is the raw number, perhaps the more meaningful one, but a little bit more difficult to interpret, is the percentage of clinical denials that result in first level appeals. And there, again, you see the big increase in quarter 3 of 17 that went with the resource allocation model. And it has been going down, I think, somewhat similar to the trend in grievances. It's certainly down below what it is, but it's not down to the level that it was prior to that. And then finally, if you go to the next page, there are 3 graphs that show the outcomes of appeals. Really 3 decisions, 3 possible outcomes. One is the initial decision can be upheld, or that decision can be overturned, or it can be partially overturned, depending on the clinical determination of the reconsideration reviewer. And we find that in almost all cases in which there is a change in the decision at the reconsideration level, it is based on new clinical information that is presented or discovered in the appeal process. So looking at the long-term trends, we find somewhere in the range of 2/3 to 3/4 of the initial decisions are upheld on appeal. Then the overturned is the lowest rate. It is probably in the 10 to 15% range. And then the difference somewhere in the maybe 15% range would be the partial overturns.
Now, you're saying that the overturned is where we tend to turn up more clinical data, or in all categories?
Well, both the, well, almost always there is some new clinical information that's available to review in the appeal. We really encourage people to submit new information. Sometimes we will go looking for it and ask for it. And so we get it sometimes when the decision is upheld, but almost universally where there is a different outcome, where it's overturned, it's partially overturned, it's on the basis of new information that changes our understanding of what the member needs. So summing it up, there are really no significant changes in the volume of service authorization requests in the past 2 quarters. The spike in the denial rate in quarter 2 of 2018 was attributed to an increase in 2 services, but that was fairly short and went back down. But then the denial rate in the following quarters tended to be back where it had been the previous 3 years. The rate of appeals of Medicaid services rose sharply in 2017 with the introduction of the resource allocation model, and there has been a continuing slightly downward trend in those appeals since then, but we're not back to the level where we were prior to the implementation of resource allocation. Again, we did not find any trends that were alarming or that we thought needed particular intervention. We also look at many of these parameters monthly, but then we'll continue to aggregate it and look at trended quarterly data going forward.
Any questions for Stephen Buck? IDD services.
Good afternoon. In your package, you have two documents. One's labeled Quarter 1 and Quarter 2, the Intellectual Developmental Disability Services dashboards. There's about 1,080,000 people living in our catchment area, and if you use the prevalence rate of intellectual disability established in 1994 by Lakin, about 1.49% of people have intellectual disabilities. So roughly about 16,000 people with intellectual disabilities live in our catchment area. And historically, state-funded programs and Medicaid serves about 15% of people with intellectual disabilities. In our catchment area, we're serving roughly 17%. So our penetration rate is high with that regard. You'll note that in Quarter 1 we served 2,727 people, and that number increased to 2,746 in Quarter 2. The reason we're seeing that increase is because of the creation of the long-term community support service, and in lieu of ICF, intermediate care facility service, that Vaya worked with the division to create back in fall of last year. On the second page of the document, you'll see very top, we increased from 348 people to 404 for that service. That accounts for the reduction in the number of people receiving non-Medicaid and B3 services during that same period. It dropped from 352 down to 314.
And if I can link back, that's where we saw the spike in service authorization requests.
Right.
New service.
Right, with that new service availability. And we're slowly moving to where really the only folks that we're serving using B3 services are adults and children that are living with their families. And then we're serving a lot of children with state funds that are living with their families because there's no Medicaid alternative if their only diagnosis is intellectual developmental disabilities. The number of people on our registry of unmet needs increased by 14 during that quarter, which that's pretty typical. We seem to get 3 to 5 requests for people to be added to our registry of unmet needs, and these are individuals that are waiting for the innovations waiver. And we actually increased the number of people on the wait list that are receiving some type of service by 1% from Quarter 1 to Quarter 2. Our innovations numbers increased by 1 in the second quarter. That's down a little bit lower than our actual allocation because of rules that the state enforces with regard to waiver renewal. I would anticipate that the number of people in the waiver will go up during Quarter 3 significantly because we were given the go-ahead to add people to slots that had been vacated effective January 1. And we're anticipating renewal of the 5-year waiver on April 1. The renewal has not been confirmed, and we were told in a conference call on Tuesday that if the new waiver period for 5 years does not start on April 1, it will likely be postponed until July 1. And that really summarizes IDD services. Any questions?
Just a word of how this plays into grievances. Of course, when people in the community hear that the new waiver is going to start in September, and then they hear that it's April, and possibly somewhere on down the road, that causes our grievances to rise because people are expecting that, on these dates that there will be services available.
And the waiver has been delayed several times. The renewal was originally supposed to be August and October and November and January, 4/1. The January we didn't get as many complaints because slots were released so that we could start filling slots. But we were developing a backlog of emergency needs. We're fortunate to have our long-term community support service because it allows us to meet emergent needs for adults. We don't really have specific tools to meet emergent needs for children under 22, so we have to piece things together using state-funded services and sometimes mental health services if the child has co-occurring issues.
So even though Carla's folks may tell people we anticipate that the new waiver will start on this date with these new services, what they hear is on that day, I'm going to get those new services, or my child's going to get those new services, which causes them to in turn call Stephanie and her folks.
I have a question where it doesn't have a wrong answer. In a perfect world, what would that 17% number penetration percentage look like? Obviously, I don't think it would be 100% because there are going to be some people who just don't, they want
Right.
services.
Hey, that's really a hard one to, the 15% of people in service is a number that's established nationally by different research groups. And it's hard to say what the perfect would be, because often the folks that we're serving are individuals that have ended up in an institution at some point, or they don't have family supports in place that can really meet their needs. So
it's not the total population by the year, it is even potential.
right, because if we were serving the total population of IDD in our catchment area, we'd be serving 16,000
Right.
people.
Right.
And there's a number of people that would probably be eligible for some of our services that we do not have data for because they're receiving services through the Community Alternatives Program for Children, as an example. Or they may be receiving services through the Community Alternatives Program for Disabled Adults, because you have those funding streams also. So that those, we wouldn't capture their numbers, but when you start considering those individuals, you're probably pushing the numbers up closer to about 24% in our region, because the county departments of social services control the CAP-DA programs and CAP-C programs. Now they do usually contract those out to a vendor to manage the case management pieces.
So yeah, because 1 in 6 doesn't seem.
Well, and you see, here's just something that's pretty astonishing about this number too. 2,727 people, or looking at quarter 2,
right.
the 2,746, that represents probably about 62% of our service budget as far as funding, between the innovations waiver, state-funded services, and intermediate care facility services, and the state development centers.
How many people are on the wait list for services?
1,379 as of 12/31. Yeah, it's in the, that's just because it was on the packet. Of course, I can usually answer that question with an exact number the first week of every month.
So, Dr. Conner, if you're looking at who's on the run list, it's still a relatively small number of the total 16,000 that we would anticipate.
Right, 2%, 9% or something like that. Any other questions for Justice Mathers? Did I miss anybody? Do you have any other business that didn't hit the agenda? I can't believe we're going to finish without people knocking on the door. That was a little smart. Well, thank you all very much.